Selamat malam Pak Gif. Bapak sudah akses co-host. Bu Irma, mungkin sudah bisa kita mulai pelan-pelan Bu Irma.
Oke,
Dan
baik, betul.
ya di Zoom-nya Filipina juga baru saja dihidupkan. Kemudian Bapak Ketum sudah hadir bersama kita di sini, mungkin masih diberikan waktu sebentar untuk kita bersiap-siap semua.
Ya, siap, betul. Pak Gatot juga sudah hadir, ya. Selamat sore Pak Ketum, selamat sore Pak Gatot.
Oke. Mungkin saya share dulu ke ini. Saya akan share untuk jumlah peserta kita yang terdaftar. Itu adalah baik, saya akan share sejumlah yang hadir, yang mendaftar adalah 717 di Zoom kita per hari ini. Jadi mekanismenya Bu Irma dan Bapak Ketum, begitu peserta mendaftar, mereka langsung otomatis dikirimkan link Zoom Indonesia. Dan sampai sore ini 717, namun yang masih di ruang Zoom baru 23, kita masih menunggu rekan-rekan untuk gabung. Demikian laporannya Bu Irma, dan kemudian kita juga sudah membagikan ini absensi dan pretest.
Ya.
Betul. Saya akan coba cek di Zoom untuk Filipina. Silakan Bu Irma, mungkin bisa disapa dulu rekan-rekannya.
Oke, selamat sore Bapak Ibu semuanya. Selamat menjalankan ibadah puasa bagi yang menjalankannya. Selamat berbuka, ya. Mungkin bagi di beberapa tempat sudah berbuka puasa. Selamat sore juga untuk Pak Gatot dan Bapak Ketum. Semoga sehat-sehat semua Bapak Ibu semua peserta webinar kita. Beli Putu, mungkin bisa di-set juga Pak Gatot sebagai co-host agar bisa unmute.
Baik, mohon ditunggu. Ya, sudah. Selamat sore Pak Gatot. Mohon maaf, sedikit menunggu untuk akses co-host.
Selamat sore, Beli Putu, Bu Irma, selamat sore. Salam sejahtera.
Nah, gaya ininya baru, tampilannya baru loh Pak Gatot. Agak pangling saya. Nah, ini di layar adalah Zoom dari Filipina saat ini. Jadi masih baru saja mulai kita lihat. Ya, belum semua hadir. Kita masih menunggu sambungan. Kemudian Mas Gatot mungkin sudah melihat layar tadi bahwa yang mendaftar adalah 717 Mas sampai sore ini. Dan yang hadir di ruang Zoom baru 27, kita masih juga menunggu sambungan. Ini di Zoom Filipina baru saja disalam-salami, belum mulai. Baik, silakan Bu Irma, mungkin kita bisa mulai pembukaan Indonesia dulu, dan mohon Bapak Ketum, mohon izin kami akan memulai untuk pembukaan Indonesia.
Siap. Mohon izin Bapak Ketum, Pak Gatot, dan Bli Putu Adi, Bapak Ibu semuanya untuk memulai acara kita. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Shalom, nama budaya. Om Swastiastu.
Silakan. Ya.
Baik, terima kasih Bapak Ketum. Yang terhormat Bapak Ketua Umum Pengurus Pusat PARI, Bapak Dr. Haji Sugianto, SPD, MAPPSC, MRI, beserta seluruh jajaran pengurus Pusat PARI. Yang kami hormati jajaran Kapengda seluruh Indonesia atau yang mewakili, dan tentunya jajaran panitia dan Bapak Ibu peserta webinar yang berbahagia. Alhamdulillah, puji syukur kita panjatkan kehadapan Tuhan Yang Maha Esa, karena atas berkat rahmat beliau kita bisa berkumpul di sore hari ini untuk mengikuti acara webinar dengan sehat walafiat. Semoga kita semua, Bapak Ibu beserta keluarga, sehat semua dimanapun berada. Pertama-tama izinkan saya memperkenalkan diri, nama saya Irma dan izinkanlah saya memandu acara lokal konten atau sistem relay acara CPD Asia ini. Bapak Ibu semua, perlu kami informasikan bahwa acara CPD Asia merupakan acara rutin setiap bulan yang digelar oleh hasil kerjasama antara 9 asosiasi radiografi di Asia, yaitu Asosiasi Radiografer dari Macau, Indonesia, Filipina, Taiwan, Kamboja, Myanmar, Hong Kong, Vietnam, dan Singapura. Dan untuk acara sore hari ini adalah acara CPD Asia yang ke-14, dan hostnya pada acara CPD Asia kali ini adalah dari Filipina, atau Philippine Association of Radiologic Technologies. Dan pada sore hari ini, Filipina mengundang 2 narasumber, yaitu Lara Gabriel dari St. Luke Medical Center, dan pembicara yang kedua adalah Gerald Carvin dari Lux Medical Center juga. Dan mereka akan membahas tentang findings in abdominal and chest imaging. Bapak Ibu semuanya, acara webinar akan dimulai tepat pada pukul 18 WIB nanti. Namun sebelumnya kita akan mengadakan pembukaan untuk peserta dari Indonesia, kemudian menyanyikan lagu Indonesia Raya, yang diikuti oleh sambutan dari Ketua Bidang Hubungan Luar Negeri dan Kerjasama Luar Negeri dari PP Pari, yaitu Bapak Gatot Santosa, dan sambutan dari Bapak Ketum, kemudian kita akan join dengan main Zoom oleh host kita di Filipina. Sebelumnya, agenda berikutnya adalah menyanyikan lagu Indonesia Raya dan Mars Pari. Untuk itu, Bapak Ibu sekalian mohon untuk mengambil sikap tegak dengan menyilangkan tangan kanan di dada. Kepada petugas Liputu dari IT kami persilahkan. Baik, Bapak Ibu dipersilahkan untuk rileks kembali. Acara selanjutnya adalah sambutan dari Ketua Bidang Hubungan dan Kerjasama Luar Negeri PP Pari, yaitu Bapak Gatot Santosa. Untuk Bapak Gatot, waktu dan tempat kami persilahkan.
Baik, terima kasih Bu Irma. Apakah suara saya dapat didengar dengan jelas, Bu Irma?
Oke, sangat jelas Pak Gatot,
Baik,
silakan.
terima kasih Bapak Ibu. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore dan salam sejahtera bagi kita semuanya. Bagi sahabat radiografer Indonesia yang saat ini tepat sedang menjalani ibadah puasa, saya ucapkan selamat berbuka puasa. Satu hal yang ingin kami sampaikan.
Positive and negative, okay.
So when we go there, we have.
Baik, sepertinya
silakan Pak Gatot.
Ya, sudah terhubung. Tapi mengawali diskusi pada sore hari ini, Bapak Ibu, sahabat radiografer Indonesia, adalah kerjasama antara pengurus pusat Pari dengan Perhimpunan Radiografer di Asia. Tadi sekilas sudah disampaikan sama Bu Irma bahwa ini adalah event ke-14. Hari ini tema yang akan dibawakan adalah mengenai abdominal imaging dan chest imaging. Mudah-mudahan kita bisa mendengar paparan dan mengambil ilmu, sekaligus mengerti bagaimana Filipina menyelenggarakan pemeriksaan dan diagnosis untuk imaging abdomen dan chest. Kira-kira demikian Bu Irma. Terakhir dari kami bahwa nanti Indonesia akan dapat giliran menjadi host di bulan Juni. Mudah-mudahan kita semua dapat memaksimalkan event tersebut, terutama karena kita sebagai tuan rumah. Kira-kira demikian Bu Irma, waktu saya kembalikan pada moderator. Terima kasih, selamat sore, Assalamualaikum warahmatullahi wabarakatuh.
Baik, terima kasih Pak Gatot atas sambutannya. Berikutnya adalah sambutan dari Bapak Ketua Umum Pengurus Pusat Pari, Bapak Dr. Haji Sugianto, SPD MAPPSC MRI. Kepada Bapak Ketum, waktu kami persilahkan.
Baik, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Yang kami hormati Pak Gatot ya sebagai Ketua Bidang Kerjasama Luar Negeri. Ini wajahnya baru Pak Gatot nih, Lebaran. Pak Putu Wadi, Pak Putu Irma, teman-teman semuanya, mungkin ada Pak Saigum juga, teman-teman di Diklat. Mohon maaf nih, barangkali saya memang di jalan ya, baru mudik. Ya, mudah-mudahan kegiatan webinar ini nanti lancar dari awal sampai akhir. Dan ini CPD untuk yang kesekian kali barangkali ya, yang akan diselenggarakan oleh teman-teman di Filipina. Selamat belajar. Memang ini waktunya kebetulan pas buka puasa, juga nanti pas tarawih ya, jadinya memang ya pas kebetulan aja. Mudah-mudahan sih tetap antusias ya teman-teman semuanya. Demikian, mari kita buka sama-sama ya acara ini dengan bacaan basmalah. Bismillahirrahmanirrahim. Terima kasih semuanya.
Safe travel Pak Ketum.
Terima kasih Bapak Ketua. Semoga selamat sampai tempat tujuan ya. Salam untuk keluarga, selamat berbuka puasa. Baik Bapak Ibu sekalian, itulah acara lokal konten kita. Mungkin sebentar lagi kita sudah bisa bergabung dengan main host kita di Filipina ya, Bli Putu ya. Kemudian perlu kami sampaikan juga, jika Bapak Ibu semua mempunyai pertanyaan terkait dengan materi yang disampaikan oleh narasumber, bisa disampaikan lewat aplikasi Pigeonhole.
Ya, tampak sedang bersiap-siap. Zoom di Filipina sedang bersiap-siap. Baru mulai hidup ya mereka.
Kami sampaikan juga Bapak Ibu semuanya diharapkan untuk seluruh peserta agar mengisi pretest dan absensi, polling awal absensi. Sebagai salah satu syarat untuk mendapatkan sertifikat dari acara CPD Asia ini.
Betul. Terima kasih Bu Irma. Jadi nanti ada dua sertifikat, sertifikat of presence dan sertifikat of attendance. Undangan PP Pari dan para Kapenda itu kami berikan attendance. Kalau teman-teman yang mengisi pretest dan post-test itu akan diberikan sertifikat of presence. Demikian, ini saya sudah mulai di Filipina sudah mulai. Kita langsung saja Bu Irma ya ke Filipina ya.
Silakan kita langsung join Zoom Bapak Ibu, selamat mengikuti acara kita.
Terima kasih. Kemudian pertanyaan nanti dapat dikirim melalui kolom chat, akan kami teruskan ke Zoom Filipina. Pertanyaan Bapak Ibu.
Kasayahang di mapatid, ramdam sa bawat awit. Sama sisig lang indah, mga puso'y lumilipad. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. At ang ngiti ng may kapal, taglay ng bawat nilalang. May lambing na tumutuyan sa buong pakiramdam. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas.
Every day, the Philippines does more than wait. Putting together new adventures. And experiences for you to try. We're making our sites better for you to see. Cooking up new dishes for you to taste. And preparing cultural discoveries for you to feel. And we're not stopping. Because we know that you deserve more. We can't wait to welcome you.
Organisasyong part ang itinatag para sa aming mga ratek ng bayang liyag sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansang Pilipinas, nating sinisinta. Si Rowen Jen, ama ng aming profesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mangaratig sa bansa Pilipinas, nating sinisinta. Isigaw at magsaya, mga radtech ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Iyas na inilatag sa malasutlang dagat. At ang bayan niyang pinili nasa dulo ng bahaghari. Kaya't 1,000 kulay nangangakit kumakaway. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. Kasayahang di mapatid, ramdam sa bawat awit. Sa masisiglang inda, mga puso'y lumilipad. Piliin mo rin ang pitulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas. At ang ngiti ng may kapal, taglay ng bawat nilalang. May lambing na dumuduyan sa buong pakiramdam. Piliin mo rin ang Pilipinas, kapulo ang kwintas ng perlas. Piliin mo, yakapin mo, kayamanan niyang likas. Piliin mo ang Pilipinas.
Every day, the Philippines does more than wait. Putting together new adventures. And experiences for you to try. We're making our sites better for you to see. Cooking up new dishes for you to taste. And preparing cultural discoveries for you to feel. And we're not stopping. Because we know that you deserve more. We can't wait to welcome you.
Organisasyong part ang itinatag para sa aming mga ratek ng bayang liyag, sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansang Pilipinas, nating sinisinta. Si Rowen Jen, ama ng aming propesyon, liwanag na hatid, dala niya ay pag-asa. Ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansang Pilipinas, nating sinisinta. Isigaw at magsaya, mga ratek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Minsa'y natuwa ang may likha, 7,000 pulo ang ginawa. Mga hiyas na inilatag sa malasutlang dagat, at ang bayan niyang pinili.
Organisasyong part ang itinatag para sa aming mga ratek ng bayang liyag, sa aming patuloy na paglinang ng kaisipan at pag-unlad ng panahon ay sabayan. Ikaw, ako, sila, tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansang Pilipinas nating sinisinta. Si Rowen Jen, ama ng aming profesyon, liwanag na hatid, dala niya ay pag-asa, ang teknolohiko, radyolohiko, tungkulin ko sa bawat tao. Ikaw, ako, sila tayo'y magkaisa. Sa medisina tayo ay mahalaga. Ito'y handog nating mga ratek sa bansa Pilipinas, nating sinisinta. Isigaw at magsaya, mga ratek ay mahalaga. Profesyong teknolohiko, radyolohiko, ipagpunyi natin sa mundo. Ipagpunyi natin sa mundo.
Hi everyone from Asia and all over the world. This is CPD Asia, online continuing professional development platform for Asian radiologic technology societies. Hosting the 14th CPD Asia is the Philippine Association of Radiologic Technologists, PART, and I am Peachy Luna, your program host. We are again grateful to our sponsor, VT Healthcare Vietnam, in helping us organize the online CPD Asia. And we are live streaming on YouTube. Please search VART and PARI channels. So you may join us live and watch a replay using the YouTube channels. This online Asia CPD is highly supported and graced by member societies' presidents, the officers and representatives. Allow me to recognize them and let us greet and welcome President of Macau Radiologic Technologists Associations, MRTA, Fernando Koch.
Hello, good evening, everyone.
President of Indonesian Society of Radiographers, or PARI, President Giek Subianto. We also have President of Vietnam Association of Radiological Technologists, VART, President Thai Van Lo.
Hello, everyone. Hello, good evening, everyone.
We also have the President of Hong Kong Radiographers Association, HKRA, President Wan Shiu Bun Nelson.
Hello, everyone. Good evening.
We also have the Singapore Society of Radiographers, SSR President Denise Chung. We have also the representative of Myanmar Society of Medical Radiation Technologists, Ian Yin Tan. We have for Malaysian Society of Radiographers, Mrs. Chan Lai Kwan. And we have President Sophie Lee of the Association of Cambodian Radiological Technologists. And for President Rolando Banares, PART Vice President, Mr. Dexter Rodelas.
Good evening, guys.
Thank you very much, dear presidents and officers. And later, they will be joining us again during the Q&A session as our panelists. So may I humbly request all presidents, officers, guests, and speakers to please open your camera for a short photo session. All right, thank you very much. Now, to formally start the program, please welcome the Vice President of the Philippine Association of Radiologic Technologists, PART, Vice President, Mr. Dexter Rodelas.
Good evening, guys and friends. I welcome all of you to the 40th CPD Asia, online continuing professional development platform for the ASEAN Radiologic Technology Societies. We hope that you will be able to learn and appreciate the discussions that our speakers will discuss in the program. We thank you all, the President and everyone for being here today. Thank you and mabuhay.
Thank you so much, Philippine Association of Radiologic Technologists Vice President, Mr. Dexter Rodelas. So this CPD Asia has two speakers, lecturers. The focus of their lecture is about actionable critical findings in imaging the chest and abdomen. We shall be having our Q&A session after our discussions. And meanwhile, you can type your questions by clicking the Q&A button in Zoom or type in your questions in the chat box. For those who are in the live broadcast via YouTube, you can also chat your questions there, and we'll hope and try to accommodate all your queries. So allow me now to briefly introduce our speaker. Our first speaker, Dr. Gerald Garvin C. Lim, is a board-certified radiologist and a fellow of the Philippine College of Radiology. He obtained his medical degree and postgraduate internship at the University of Santo Tomas, Faculty of Medicine and Surgery in 2015. He then had his residency in general diagnostic radiology at St. Luke's Medical Center, Quezon City, and has recently concluded his fellowship in CT-MRI, CT-MR imaging in the same institution. He has presented various case discussions and research papers, both locally and abroad. His special interest dwells in cardiothoracic imaging, and he will be talking about critical findings in the chest in this session. Please welcome our first speaker, Dr. Gerald Garvin C. Lim.
Good day, everyone. I'm the findings in the chest. I have no relevant disclosures pertaining to this talk. My objectives are to define critical results and to enumerate select critical findings in the chest, with emphasis on radiographs and cross-sectional imaging. So critical result is defined as any result or finding that may be considered life-threatening or that could result in severe morbidity and require urgent or emergent clinical attention. Each facility has leeway to define its own critical tests and results, and thus there is really no standard list for either category. But what is essential is that it requires rapid communication of results, whether normal or abnormal. So now we tackle the critical findings in the chest. First one is pneumothorax. It's basically air within the pleural space and is most commonly from rupture of subpleural plebs, as tiny lucencies at the periphery of the collapsed lung. It most commonly occurs in 20 to 40-year-old males who are asthenic and are smokers, and is characterized by acute onset of pleuritic chest pain, dyspnea, or back or shoulder pain. On chest radiograph, in an upright position, these are the radiologic signs. You will see an area of lucency with no pulmonary markings. It's pointed by the white arrows, and these represent the air in the pleural space. The yellow arrows, meanwhile, point to a thin white visceral pleural line associated with lung collapse, which is the single best sign for pneumothorax. The red arrow points to a depressed left hemidiaphragm. And these are the classic findings, and this is easy to identify, especially when the pneumothorax is massive. But what if the patient is in a supine position? Will you still see these classic signs? Well, yes, especially when the amount of pneumothorax is moderate or large. The problem is when it's minimal, and the picture may look differently. So in a supine position, air may go to different spaces. So if the patient is lying down, the air will go to the anteromedial portion, and this is the earliest location. So the pneumothorax may not display the classical signs. Instead, the pneumothorax may be demonstrated by looking for the following signs, namely the outline of the medial diaphragm under the cardiac silhouette and the deep sulcus sign. This is a pneumothorax in the infrahilar anteromedial space due to vehicular trauma. You see in the supine radiograph, there's a sharp delineation of the left heart border and the deep anterior cardiophrenic sulcus. while the corresponding axial CT of the lung base shows substantial air collection in the pleural cavity at the anterior cardiophrenic sulcus. In a supine patient, air may also outline the anterior portions of the hemidiaphragm and cause visualization of the anterior cardiophrenic sulcus, when both the diaphragmatic dome, which is outlined by the white arrow, and anterior portions of the diaphragm, outlined by the pleural air, as depicted by the black arrow. If both of these are visualized, the double diaphragm sign is produced. The second most common location is at the subpulmonic space, as in this case of a middle-aged woman with interstitial pneumonia. Supine radiograph shows a hyperlucent upper quadrant of the right abdomen, and corresponding coronal CT image clearly depicts the inferior surface of the lung, a sharply outlined diaphragm, an IVC, and a deep sulcus sign as well. This pneumothorax, meanwhile, is in the posterior medial space of an elderly man with chronic obstructive pulmonary disease. A supine radiograph shows a lucent triangle with a partially collapsed left lower lobe. Corresponding CT image of the lung base shows pneumothorax in the posterior medial space, and the left inferior pulmonary ligament, which is the linear structure between the mediastinum and the left lower lobe, is clearly visible. This is a pneumothorax in the apicolateral space of an elderly male due to esophageal perforation caused by endoscopy, which resulted in pneumomediastinum, pneumothorax, and subcutaneous emphysema. This is a supine radiograph with corresponding coronal CT images showing the visceral pleural line in the apicolateral space, the pneumothorax in the intermedial space and subpulmonary space, pneumomediastinum, and subcutaneous emphysema are also visible. There are no vascular markings that exist beyond the visceral pleural line. However, there are potential mimics for pneumothorax, so you have to be careful, and here are some examples. This is an elderly male with sepsis. You can see that there is a linear opacity nearly parallel to the right chest wall extending from base to the apex. Here's a closer view. The lung marks are evident peripheral to this line, implying that this is not air in the pleural space. This is actually a skin fold. Skin fold is usually mistaken as visceral pleural line, and they typically occur in the elderly with loose skin. And to differentiate the skin fold and pneumothorax, absence of increased lucency laterally and demonstration of lung markings across a curvilinear shadow likely represent skin fold. Now in this image, it is focused on the left upper chest and you can see a white line shown by the arrows. Could this be a visceral pleural line? The answer is no. This is the edge of the scapula, and you can easily follow the contour of the scapula to make sure it does not project over the chest. In this image, there's an area of lucency in the right upper lobe that is devoid of pulmonary vascular markings. This looks just like a pneumothorax. There is also white linear opacity shown by the yellow arrow that looks like a pleural line. This is actually bullous emphysema. Distinguishing pneumothorax from bullous emphysema can be difficult, but it is important to distinguish them since management may vary. Now in a tension pneumothorax, air from a ruptured lung enters the pleural cavity without means of escape, and as air pressure builds up, the affected lung is compressed and all of the mediastinal tissues are displaced to the opposite side of the chest. In cases where classic features are not clearly present, a number of techniques can be employed, such as the lateral decubitus radiograph. It should be done with suspected side up. The lung will then fall away from the chest. So if the suspected pneumothorax is on the right chest should be up. That is the left lateral decubitus position. Inspiratory and expiratory projections are one technique that can be used to make pneumothorax more obvious. In expiratory chest radiograph, the lung becomes smaller and denser, and the pneumothorax remains the same, thus making the pneumothorax easier to identify. But if it is impossible to identify in radiograph, then we should still request for a CT. Pneumomediastinum is the presence of extraluminal gas within the mediastinum. Gas may originate from the lungs, trachea, bronchi, esophagus, and peritoneal cavity, and track from the mediastinum to the neck or abdomen. It commonly results from blunt or penetrating chest trauma, or maybe secondary to neck, thoracic, or retroperitoneal surgery, or even perforation of the esophagus or trachea. These are chest radiographs, PI lateral views. You see the blue arrow points to a linear lucency under the mediastinum, and it is continuous from right to the left hemidiaphragm. This is the continuous diaphragm sign. The red arrow, meanwhile, points to a lucency at the inferior cardiac border. This AP radiograph demonstrates pneumomediastinum outlining the left subclavian artery and possibly the left carotid artery, and is called as the tubular artery sign. Another lateral radiograph demonstrates the ring around the artery sign, which is seen on lateral chest radiographs as a well-defined lucency along or surrounding the right pulmonary artery. The Nacclerio V sign is a sign described on the plain film in patients with pneumomediastinum occurring often secondary to esophageal rupture. It is seen as a V-shaped air collection with one limb outlining the left lateral mediastinal border, while the other limb between the parietal pleura and left hemidiaphragm. The Spinnaker sign is a sign of pneumomediastinum seen on neonatal chest radiographs. It refers to the thymus being outlined by air, with each lobe displaced laterally and appearing like spinnaker sails. It is distinct from the sail sign appearance of a normal thymus. So can you identify the critical finding in this radiograph? Okay, so the ET tube is too low. The tip of the endotracheal tube is in the right mainstem bronchus. So this is a critical finding, and you need to relay this right away because right mainstem bronchus intubation will lead to atelectasis of the entire left lung and hyperinflation of the right lung. Most often, endotracheal tubes are malpositioned in the right mainstem bronchus because of the shallower angle of the right main bronchus makes the trachea than does the left mainstem bronchus. Here's another radiograph showing a malpositioned ET tube. In this case, the tip is at the bronchus intermedius, and this is much lower compared to what I showed you a while ago. Bronchus intermedius intubation may lead to atelectasis of the entire left lung, the right upper lobe. Here's another malpositioned tube. A linear opacity seen coursing the midline, and it made a loop going up, and tip is seen at the level of T2. This is a malpositioned feeding tube. In this radiograph, the feeding tube is not inserted to the adequate length, so further advancement of the NGT is needed for this patient. The ideal position should be in the subdiaphragmatic position, identified on a plain chest radiograph as overlying the gastric bubble. Ideally, it should be at least 10 centimeters beyond the GE junction. Here you have a chest PA view with a large rounded opacity or focal bulge with rim calcification at the region of the aortic knob. This finding is highly suggestive of an aortic aneurysm. Although without the vascular calcification, this may also suggest a superior mediastinal mass. A thoracic aortic aneurysm is the ballooning of the upper aspect of the aorta, which is above the diaphragm. And the term aneurysm is used when the axial diameter of the thoracic aorta reaches or exceeds 5 centimeters. On chest radiograph, the most common finding of aortic aneurysm is not really focal bulge, but just widening of the mediastinal silhouette, enlargement of the aortic knob, and tracheal displacement. In aneurysms may be complicated by dissection. Aortic dissection is the most common form of acute aortic syndrome. It occurs when the blood enters the medial layer through a tear in the intima and tracks along the media, form a second blood-filled channel within the wall, and patients may present with anterior or posterior chest pain and a tearing sensation in the chest. And CT angiography has a reported sensitivity and specificity of nearly 100%, so it has to be done in patients with suspected aneurysm and dissection. Complications include abdominal organ ischemia or embolic stroke. And in some cases of aortic rupture, especially those involving the ascending aorta, the involvement of the coronary arteries may result in infarct or occlusion, so it may be warranted to do dedicated CT of the coronary arteries in this case. It is also imperative to do 3D reconstruction, as shown here. So let me show you another critical finding more often found in young children. This blue arrow points to an opacity. Actually, this is a foreign body, an earring to be specific, which is lodged in the right main stem bronchus of a 25-year-old. Again, the right main stem bronchus is a common location due to its posterior location, shallower angle to the trachea and wide diameter. With non-radio-opaque foreign bodies, indirect signs of aspiration will include focal overinflation or atelectasis. Another critical finding is severe narrowing of the airway, like in this case resulting from a large lobulated thyroid mass. Lastly, pulmonary embolism refers to embolic occlusion of the pulmonary arterial system. The majority of cases result from thrombotic occlusions such as DVT or deep vein thrombosis, usually coming from the lower limbs. And these are depicted as filling defects within the pulmonary arteries in a patient with dyspnea, chest pain, and even hemoptysis. So you have gone through the most common and important critical findings in the chest, which we cannot miss during our duties and should warrant rapid communication with the radiologist or clinician in order to add value in patient care. These are my references. Thank you very much for your attention. I hope you learned something today.
Thank you very much, Dr. Gerald Garvin Lim. So now let's proceed to the second speaker, and let me introduce her to you. Dr. Lara Gabriel L. Lim is a board-certified radiologist, and she obtained her medical degree at the University of Santo Tomas, Faculty of Medicine and Surgery, Manila, Philippines. Her postgraduate internship at Chinese General Hospital and Medical Center. She then had her residency in general diagnostic radiology at the University of Santo Tomas Hospital, and has recently concluded her fellowship in CT/MR imaging in St. Luke's Medical Center Global City, Taguig, Philippines. Dr. Lara Lim has presented various research papers, case discussions, and publications, and special interest in breast imaging and abdominopelvic imaging. She will be talking about actionable findings in abdominal imaging in this session. Ladies and gentlemen, let's welcome our second speaker, Dr. Lara Gabriel Lim.
Good day, everyone. Thank you for having me today. We are going to be talking about actionable findings in abdominal imaging. I have no relevant disclosures for this talk. Let us begin with a quick view of the objectives of this presentation. We will start off with an introduction of the concept of actionable findings in medical imaging, categorization of these findings, and finish with a few examples of findings from each category. Let us begin. The American College of Radiology Workgroup defines actionable findings as imaging findings that require non-routine communication with a referring physician because of urgency or unexpectedness of a certain result. Both the radiologic technologist and the radiologist play key roles in identifying these findings in daily practice, as not recognizing these critical results may inadvertently delay treatment and lead to patient morbidity. This is particularly important in asymptomatic patients who come to the imaging center with incidental actionable findings detected on routine imaging. The ACR workgroup categorizes actionable findings into three sets, based on severity and level of urgency. Category 1 findings generally require non-routine communication within minutes of detection. Category 2 findings within hours, and Category 3 findings within days. It is important to acknowledge the vital role of the radiologic technologist here. The radiologic technologist is the very first member of the imaging team to see the diagnostic images of a patient and has the opportunity to alert the radiologist to the presence of an actionable finding. Please keep in mind that some actionable findings may fall in a gray zone where different institutions categorize it differently, perhaps due to differences in experience or prevalence of a finding in their local setting. Now let's begin our discussion with Category 3 findings first. Category 3 findings, although unexpected, generally do not require immediate treatment. Follow-up imaging is still needed, but not for a few months, and non-routine communication can be done in days or weeks. These include findings such as incidental probable malignancies or a non-malignant finding that still requires long-term follow-up. Findings placed in Category 3 should not pose an acute danger to the patient. Findings that pose acute danger to the patient are either placed in Category 2 or in Category 1. Category 2 actionable findings are clinically significant observations that require non-routine communication with the clinical team within hours of detection. While more urgent than Category 3 findings, actionable findings in this category do not pose the same degree of severity of Category 1 findings. To help explain this better, let us look at some examples. Ascites. Low volumes of ascites are often placed in Category 3. However, significant volumes of ascites warrant more urgent clinical attention and are placed into the Category 2. Ascites can be transitive or exudative, based on their etiology. Here we have a 60-year-old male with significant amount of hypodense fluid collection within the abdomen. On review of his clinical history, he was found to have cirrhosis and hepatitis C. This is a case of transitive ascites. Intraperitoneal fluid collections can be hyperdense when it has hemorrhagic content. This patient was a 40-year-old female who came in with a week-long complaint of nonspecific bloatedness. She denies any trauma to the abdomen. On non-contrast abdominal CT imaging, there was a sizable collection of hyperdense fluid within the pelvis, between the uterus and the rectum. This imaging finding was relayed to the clinical team and further workup was done and the patient was managed accordingly. Category 2 actionable findings also include intra-abdominal infections, as these require urgent treatment. These two patients came to the imaging center with a complaint of right lower abdominal pain. Axial non-contrast abdominal CT at the mid portion of the abdomen shows a marked stranding of the intra-abdominal fat around the colon. This was a case of acute diverticulitis. In this second patient, axial non-contrast abdominal CT of the lower part of the abdomen shows a bowel look-alike with a lot of fat stranding surrounding it. This was the inflamed appendix in this case of acute appendicitis. Both of these examples highlight an important point. In abdominal imaging, fat stranding is a reliable clue to intra-abdominal infection. Even if junior members of the imaging team are unsure of the pathologic organ, junior members of the imaging team should be encouraged to alert senior members of the staff to the presence of definite intra-abdominal fat stranding, as this is a good indicator of a Category 2 actionable finding. Let us look at a few more examples. Our next patient is a 52-year-old male who had otherwise been feeding well until after he had awoken that morning. On contrast abdominal CT, fat stranding was seen around the pancreatic head. This was a case of acute pancreatitis. How about this second case? This was a 22-year-old male who had left-sided abdominal pain. The ordering physician had requested for a non-contrast abdominal CT because he was quite unsure of the patient's diagnosis. The scan showed fat stranding around the left kidney, explaining the patient's left-sided abdominal pain. MRI scans also show intra-abdominal fat stranding quite clearly. Here we have a 72-year-old female who had what she claimed to be an odd feeling in her stomach. T2 weighted imaging with and without fat suppression shows fat stranding as hyperintense signals around this very much inflamed gallbladder. There is much more evident fat stranding in the fat suppressed image. Notice that there are also fat stranding hyperintensities outside the abdomen in the right side of the abdominal wall. This was a case of acute cholecystitis. Finally, we have Category 1 actionable findings. These findings can lead to death if not acted upon in a timely manner. Direct verbal communication with the clinical team is generally required within minutes of detection. Our first example is unexplained pneumoperitoneum. Air is normally seen within the bowel loops. Pneumoperitoneum is extraluminal air and calls for surgical management. In this first case, we have a 50-year-old male patient with abdominal pain. Here we see this very hypodense collection in the non-dependent portion of the abdomen. This is pneumoperitoneum. Images of the lower abdomen of this patient showed that he had acute diverticulitis that had ruptured. Do keep in mind that some patients, particularly the elderly, may present atypically and without symptoms, and you might catch an asymptomatic patient with pneumoperitoneum. Here we have a second patient. This time he is a 30-year-old male that had been complaining of recurrent right lower abdominal pain. This non-contrast CT of the abdomen is set in the lung window. Using the lung window, we more easily see these tiny air locules within the left upper quadrant of the abdomen. Images of the lower abdomen of this patient showed that he had benign pneumatosis coli. Remember, even if the primary disease is benign, unexplained pneumoperitoneum is a Category 1 actionable finding and should be relayed to the clinical team as soon as possible. Another Category 1 actionable finding is intestinal obstruction, particularly one that shows decreased blood supply to the affected bowel loops. Let us look at two case examples. This first patient is a 60-year-old male with abdominal pain. There are dilated small bowel loops in the low-mid abdomen of this patient. Pointed by the blue arrow is a point of transition from dilated to focally narrowed bowel. The second patient is a 65-year-old female with similar symptoms. This time, though, there is much more diffuse involvement of the small bowel loops. A focal point of transition from dilated to narrowed bowel is also pointed by the blue arrow. Both of these CT studies are contrast enhanced, but the difference of these two case examples is the degree of bowel wall enhancement. In the first case, there is clearly decreased enhancement of the affected bowel loops. This suggests decreased blood supply of the affected bowel and is in need of immediate intervention, clearly a Category 1 actionable finding. In the second case, although much more of the small bowel loops is affected and dilated, all of these enhance uniformly. There is no immediate threat to bowel integrity. Institutions may choose to put the second case into either a Category 1 or Category 2 actionable finding. Active intra-abdominal bleeding is another example of a Category 1 actionable finding. This example case is a CT angiogram of the kidneys in a young male who had a motor vehicular accident. The different phases of the CT angiogram clearly shows contrast extravasation from the left kidney parenchyma into a large subcapsular hematoma, contrast extravasation from large vessels like the aorta and aneurysms of the aorta are also Category 1 actionable findings. We end this presentation with some concluding statements. Actionable findings require non-routine communication with the clinical team to prevent delays in treatment and patient morbidity and sometimes mortality. Categorization of findings is based on severity and urgency, but these are only guides and not rules. Actionable findings may be present in both symptomatic and asymptomatic cases. The radiologic technologist and the radiologist play key roles in communication of these actionable findings to the clinical team. Finally, I end with this statement from the ACR workgroup. The ultimate judgment regarding any specific course of action must be made by the physician involved, with particular knowledge of the condition of the patient and the practice environment. Thank you very much for your attention. Have a good day, everyone.
Thank you, dear speakers. I'd like to call back again our presidents and our panelists. But while we are waiting for them to open their cameras, may I greet and welcome the president of Taiwan Association of Medical Radiation Technologists, TAMRT, President Chun Yuan-Tu. President Tu. Oh, so we can now see President Denise Chu from Singapore Society of Radiographers. Hi, Miss President Denise Chu.
Hi, good evening, everybody. I'm sorry I was a little late, but it's so really nice to see everybody here for the 14th Asia CPD. And thank you very much to our two very clear speakers. Their presentations are very good and very easy to follow. Thank you, doctors.
And attending for PARI President, Indonesian Society of Radiographers, Mr. Putu Adi Susanta. Yes, thank you, Sir Susanta. So welcome back again, everyone. I'd like to call the panelists and welcome your questions here. You can just unmute your microphone if you want to start with the questions. Or I can start with question. All right, so while we are waiting, I'd like to address one question for Dr. Lara Lim.
I have a question for.
Oh, yeah, okay, sure. You first, sir.
Yeah. I have a question first for Dr. Giron. I see you have a lot of imaging. I think you were your presentation, your lecture very nice. And my question for you, most now in most Israel technology now they have a new technique like a subtracts everything. I want to ask you, how about your center? Like for example, in my center, the first and most not normal in check X-ray. The most radiologists in my center, they have a request please move to CT6. They have a request for CT scan again for check something, because a CT scanner for many information for patient, for doctor. The first question. How about in your center? It most like in my question, like in check X-ray now, like in my screening. And then in most radiologists, they only use a check it rate for like in screening. If ever not normal, they move to in. They request to move to in CT scan for check again everything. The first question for Dr. Jeroen. The second doctor for Jeroen, I see in your presentation have a pulmonary embolize. I don't know how about your center. After COVID-19, some people have embolized the pulmonary arterial. How about in your center? You usually for CT scanner for pulmonary for checks embolize or not embolize in pulmonary arterial in your center. Okay, the two questions for in general.
Okay. Thank you, Mr. Taiwan Lok, for those questions. So for the first one, yeah, it depends. It's the same in our institution. There is the clinicians when they would request for imaging findings. Number one, there should always be an indication on why they will be requesting either an X-ray or a CT scan. As we know, there are a lot of things that we can see, for example, in X-ray, but we can clearly delineate in CT or even in MRI. So, but if ever, for example, the request is not very clear, we usually do call them and then we confirm if what particular finding they would want to confirm in the imaging study. So for the second, during COVID, yeah, we see a lot of pulmonary embolism, especially during the alpha and the beta variant waves, but not much in Omicron. And during those times, when it was starting, the clinicians would usually base it on the blood test. They would do D-dimer, and then if the D-dimer, the blood test came out to be very high, the level is very, very high, they would proceed with CT scan to confirm if there is really pulmonary embolism. Now, in our center, we use multi-detector CT, and the scanning is usually, it has to be, you have to use the thinnest detectors available. So that's around 0.625 millimeters. With smooth reconstruction, and I believe most of the centers are already have this technology. But usually, for example, in the Philippines, in far-flung places, the scanners are not quite old. So in those cases, 1.25 millimeter thick cuts are already sufficient. So of course, we have to make sure also that the contrast injection has to be rapid. It has to be 5 milliliter per second, and the scanning has to begin from the pulmonary arteries and when the left atrium is opacified. This in most scanners, you already have the automatic triggering capability. So the delay is also important. You have used the delay of around 10 to 15 seconds if the pulmonary artery opacification is used. So usually in the clinical side, what's important in the clinicians, for the clinicians, are the involvement of the main pulmonary artery in the right and the left pulmonary artery, not so much with the smaller branches. But of course, for our it is our duty as radiologists and radiologic technologists, of course, to give them the best quality images and best interpretation that we can.
That mean in I think the second question in Dr. Yiran, you told me in Philippines now also, if for example if patient have a D-dimer have a higher chest for pulmonary arterial embolize Good morning, Arturo.
Yes. Yes.
Yeah, I think, yeah. Okay. Thank you, Dr. Jeron. I have two questions for Dr. Lara. The communication teamwork for diagnosis in very important, very important. I want to learn from you how many people in communication team with one if you see one difficult case, how many people can you discuss in communication? You discuss how many people, how many radiologists, how many technologists you can discuss together, how many people. And I think if my center now we have we not delay in the next day. Most radiologists and technologists in my center, they discuss the communication together in the same day, because we have discussed, they have a discuss and the same day by impact system and not only back system, we only send to in cloud for everybody can discuss together. And in my center, I don't know, usually in my center, usually in the same day we finish and discuss together. We communication team in the same day. But I don't know, because in your presentation tell me sometime we day or next day. How about in your center? You will tell everybody how many radiologists and technologists and communication team. And the first question, and the second question for Dr. Lara. In or infection, but I see some imaging some case enough for diagnosis. Some case burst in with contrast for diagnosis. My question for you, usually in your center, abdominal infection, in some case you don't use the contrast, with contrast enough, or with contrast enough, but in a contrast enough. When with contrast, when with contrast, some case in abdominal infection. The second question for Dr. Lara.
Hi, thank you, President Taiwan Block. So in my experience, I've been able to work in 2 imaging centers already. In the first center, we had a very small team. So I think in our CT center, we had like roughly 6 or 7 radiologic technologists with us. In our MRI center, we had 3, and then several radiologists. In the second center I was working with, we had a big number of radiologic technologists. But you see, each patient that comes into the imaging center, they're only assigned maybe a couple of radiologic technologists, right? So we rely on that smaller team of radiologic technologists to alert us of actionable findings or critical findings in a certain patient. As for the workflow, yes, I agree that most of the time, within the same day, imaging findings are already relayed to the attending physician or the requesting physician or the emergency room team, actually. But there are some cases, especially when the center has a large volume of patients, that category 3 findings in particular are not immediately relayed because there are more category 1 or category 2 findings that have to be relayed first. So we have to queue those, and maybe sometimes if they do reach a second day or a third day before they're relayed to the clinical team. In the smaller center that I worked with before, because we had smaller number of patients, even category 3 findings, we were able to relay within the same day. So it really depends on the practice that you are at. I would like to suggest that most imaging centers should have a meeting or a protocol that they will follow whenever they encounter these findings. So how they will handle it, who will relay, and if the radiologic technologist or the doctor will relay the findings to the attending physician or the requesting team. The second question, for category 2 findings involving abdominal infections, right? So sometimes will or request a non-contrast CT study. It's like a preliminary scan to just see if there is indeed something wrong. When they reach us and we're informed that there are fat strandings indicative of some sort of abdominal infection, we immediately call the requesting physician and we tell them, oh, we're thinking about that this is a abdominal infection. You might want to do a contrast study. If they do decide to do a contrast study, we'll do that, and that would confirm if there was abdominal infection or something else. Unfortunately, there are patients that cannot go to the contrast route because of, let's say, kidney problem, or maybe they're not stable to do the contrast study. In those cases, if the attending physician thinks that clinically their symptoms do coincide with abdominal infection, they may opt to forego the contrast study already, and we'll manage the patient as a case of abdominal infection with the non-contrast scan.
Yeah. Thank you, Dr. Jeroen and Dr. Lara. After me today, to the after for us many information, and thank you so much to Dr. Jeroen and Dr. Lara, many information for us. Thank you so much. Yep.
Thank you.
Thank you.
Yes, so we have a question here for Dr. Lara. Question is, all imaging procedures have generated reports to communicate findings. What is so special about actionable findings?
Yeah, that's a good question. So I agree, all imaging reports will have a finding that's given out to the patient and to the requesting physician. But our discussion today was for actionable findings. And if we follow the American College of Radiology's recommendations, they suggest that we have this form of non-routine communication. That is, we go out of our way to contact the attending physician or the requesting physician to tell them about imagings that need urgent actions or urgent treatment, or imaging findings that might be missed out by just simply giving them a piece of paper. So that's the importance of non-routine communication. It's the term to describe the form of communication is non-routine. Like for category 1 findings, the recommendation is actually verbal communication, calling up the physician. If they're not at the ER, or if they're from another imaging center that's with our center, the recommendation is for us to call them up to let them know that their patient appears to have this certain that requires urgent treatment. So yeah, that's the importance of relaying actionable findings or critical findings in comparison to simple written
yes,
report.
Dr. Lara,
Yeah.
there's a question from the participants here. I think this is somewhat related. His question is about, are you open to having the rad techs to directly alert possible critical findings to the attending requesting physician, a routine channel of communication upon detection? Or would you suggest that radiologic technologists imaging findings?
Yeah, thank you for that question. Yes, I agree that the radiologic technologies has an important role here. Whenever there's a need to relay actionable findings, recommendation would be to inform your team first, because most often certain findings have to be discussed first before they're alerted or they're sent out to beyond the imaging center itself. So I would suggest that you either alert a senior radiologic technologist and then you together go to the radiologist consultant that is on duty so that you can discuss if what you're thinking about is really what's happening inside the patient, or if you have to suggest other procedures that can confirm your suspicion.
Yes, thank you very much, Dr. Lara. And then next we have question for Dr. Gerald Lim. Yes, so the question here is, how do you relay the critical findings in your institution? What and specifically, another question is about the case of pulmonary embolism. A question is, can you give the protocol in your institution for diagnosis of pulmonary embolism?
Okay, thank you. So for relaying the critical findings in our institution, actually it was already discussed by Dr. Lara earlier. No? So we also follow the American College of Radiology guidelines. So basically upon scanning, the radiologic technologies are usually the first in line to recognize the critical findings. So in the event that there is any suspicion that there may be a pneumothorax, for example, they have to immediately call the resident on duty, whom will then validate this finding together with the consultant radiologist. And we usually call the clinic to relay the findings. After relaying, we document it in the PACTM, and then usually we have to relate critical findings within a 15-minute time period. Audit of compliance with regards to turnaround may differ and may vary from it. So for the second question regarding the pulmonary embolism protocol, I believe I already discussed this earlier also. So again, we use multi-detector CT in our institution. We use thin 0.625 millimeter with smooth reconstruction algorithm. And then the contrast has to be injected rapidly in the 5 milliliter per second, and scanning should begin at the level of the pulmonary artery or the left atrium as it is opacified, and then we do 10 to 15 seconds delay. And again, the important thing is that the main pulmonary arteries, the right and the left, are all opacified and are free of motion artifacts as much as possible.
Thank you, Dr. Gerald Lim. Yes, a question for Dr. Lara. Dr. Lara, can you explain why there is a gray zone when classifying actionable findings?
Yeah, okay. So the classification scheme that's given by the ACR is just a recommendation. It's only a guideline. And in their published guideline, they opted not to give black and white table categorization because oftentimes practice experience or a local practice setting or prevalence of disease can affect how conditions are managed medically. So sometimes some institutions may want to treat acute appendicitis, for example, medically with antibiotics, as opposed to some centers who opt to treat appendicitis more aggressively using surgery. So many times also local guidelines, like for example, here in the Philippines, the Philippine Medical Association or the Philippine College of Radiology, they can also publish guidelines that affect only the local practice, the local practices. So these can change per practice setting. So a recommendation in the United States or a recommendation in other countries may not be the same for that in your country. Also, recommendations from another part of your country may not be the same as the part of the country you're in. So it is possible that one imaging center places one condition into category 2, and another imaging center places that condition in category 1. So it really depends on the institution you're in and how the doctors or the clinicians in your institution would opt to treat that certain condition.
And another question for you again, Dr. Lara. Can you give more examples of category 3 findings?
Okay. Okay, so category 3 findings are those findings that can be followed up after a few months from the imaging procedure that they had done. So these are commonly incidental or unexpected benign or possibly malignant tumors that don't have concurrent acute conditions, like for example obstruction. Let's say small liver tumor that doesn't have portal venous thrombosis or biliary obstruction, so the patient does not have any pain associated with it. Or for example, colon carcinoma that doesn't cause bowel obstruction. So again, the patient is asymptomatic, but they do have something, a condition that needs to be worked up later on in the coming weeks or the coming months. And sometimes because the radiologic report, the written report, is simply given out to the patient, sometimes the attending physician may miss out on it, or possibly the patient does not go back to their attending physician right away. There's sometimes a need for us, the imaging team, to go and tell the attending physician using this non-routine communication that we're talking about, so that the physician will be the one to spearhead the workup and not delay treatment, because it's understandable, like if the patient has colon carcinoma and their workup is delayed for weeks or months, by the time that they're worked up, possibly that colon carcinoma has metastasized and the patient has poor prognosis. And this is what we're trying to prevent, the part where the patient develops metastasis or other conditions that complicates things. So that's why category 3 findings include those disease conditions that also require longer term follow-up. So possibly malignant, we're not really sure yet, because the patient is asymptomatic or the clinical symptoms of the patient do not coincide with it to require longer follow-up within months or possibly even years. So yeah, those are examples of category 3 findings.
Yes, thank you, Doc. Here from the participants, we have from Sherlene Reyes. Is there an instance that when you give a contrast, the aneurysm was triggered or a more serious condition came out? How will you manage if that case happened? So
okay, so usually abdominal aortic aneurysms, they come in the imaging center with symptoms, okay? So also a patient's clinical conditions, like for example, their risk factors or patient characteristics, they also indicate to us that the patient has possible aortic aneurysm. Knowing this, we can scan this patient with the aortic protocol, the aortogram protocol. I have not personally experienced or seen a patient that had no aneurysm that ruptured because of the aortogram protocol. But if a ruptured aortic aneurysm is found on the aortogram, the CD aortogram, these are immediately relayed to the clinical team. Also, in the centers that I have been working with, whenever the patient has a suspicion for a ruptured aortic aneurysm, has a member of their team there with us when we do the scan, so they know right away that the patient has a ruptured aneurysm and they're sent for treatment immediately.
Yeah, so Dr. Lara, I think you can also read the Q&A section here. The first question there actually is about ruptured aneurysm. This anonymous attendee is asking it for category 1. And if it is it still that you inject contrast agent in such case?
Yeah, so it is, yes, it is a category 1 finding and it needs immediate. Most of the time, we do not know that the aortic aneurysm is ruptured. Okay, so when we do the aortogram procedure, we inject the contrast, and that's when we find out that it has indeed ruptured. Sometimes when we do the non-contrast part of the study, we see that there are a lot of fat stranding and possibly even hyperdense fluid around the aorta, and that raises the suspicion for ruptured aortic aneurysm, but we need the contrast to confirm this.
Thank you, Dr. Lara. For Dr. Gerald, these are, I think, extra specific questions. This participant is inquiring about other techniques that you use for suspected foreign bodies in airways. And can you also share CT protocol adjustment that you do or that you do onto patient that is over?
Okay, so for techniques in suspected foreign bodies in airways, we can also do, just like in tension pneumothorax, we can also do the expiratory phase imaging in X-rays or in CTs. So if the foreign body is obstructive, it will detect air in the air trapping in that particular segment, lung segment. So it will appear more hyperlucent. Because normally in expiratory phase imaging, we expect that the entire lung would appear as ground glass attenuation or would be hyperdense. So we can do that for suspected foreign body. So for the overweight or obese patients, so you can set the reconstruction algorithm to around 2.5 millimeter thick, and most of the time this will reduce the noise of the scan, and yeah, it will be interpretable already.
Yeah, I think this next question is also for you from Can Fan from Vietnam. Question is lateral decubitus chest view is always used for critical care, in critical care, and when do you use it?
Okay, so I do not think that it is always used, but it has to be done if there is always a equivocal finding. For example, in cases wherein the classic features of a pneumothorax or even pneumoperitoneum is not clearly visible on the conventional views of the lateral. The principle behind this again is that the affected lung in pneumothorax, they would tend to fall away from the chest wall. So if the suspected pneumothorax, let's say it's on the right chest should be placed up, and that's the left lateral decubitus, right? And when when the suspected pneumothorax is on the left chest should be on the upside, and that is the right lateral decubitus position.
Yes, thank you, Dr. Gerald. There is also a question posted in the Q&A box. Why is triple rule out CTA rarely done? Any technique to acquire a good quality image of the aorta, coronary arteries, and pulmonary arteries?
Okay, the triple rule out CTA. Actually, in our institution, it's not also routine, and I think the centers that are particularly adept to this are those with cardiac capabilities. So I guess it's more of the cost, of course,
Bapak Ibu, Bu
and
Irma,
the
kita
resource
selesaikan dulu
and
sesi
the
untuk pada malam
availability of
hari ini.
the
Mas
interpreter
Gatot mohon izin
radiologists at
untuk
that
menutup
time.
karena
And
baterai
for the
Ibu tuh. Ya, Bapak Ibu semuanya, sepertinya ada gangguan jaringan dari host kita di WIB Jakarta sebagai tim IT PP Pari. Sekali lagi kami ucapkan terima kasih atas partisipasi Bapak Ibu semuanya dalam acara CPD Asia yang ke-14 ini. Dan sampai jumpa lagi di CPD Asia berikutnya. Jangan lupa diisi kehadiran akhir dan post-testnya untuk mendapatkan sertifikat CPD Asia ini. Dan sertifikat nanti akan dikirimkan ke email Bapak Ibu semua sesuai dengan email pendaftaran saat pertama kali mendaftar. Sekali lagi terima kasih kami ucapkan karena telah join di acara webinar ini. Sampai jumpa di acara berikutnya. Selamat menunaikan ibadah puasa, selamat malam.
Terima kasih Mbak Irma. Teman-teman semuanya, terima kasih atas kehadiran dan
Mas Hidayat mohon izin untuk menyelesaikan. Ternyata baterai laptopnya tidak support sampai akhir, saya dia di luar. Jadi sepertinya sudah cukup. Sudah mau berakhir juga Pak Hidayat.
Ya, nggak apa-apa Pak Mas Bibutuh. Terima kasih.
Terima kasih Mas.
Dan tim semuanya juga terima kasih Mas Gatot dan tim semuanya. Teman-teman semuanya, kami juga mengucapkan menjelang Hari Raya Idul Fitri, Pengurus Pusat Perhimpunan Radiografer Indonesia menyampaikan selamat memperingati atau selamat menyambut Idul Fitri 1 Syawal 1443 Hijriah. Taqabbalallahu minna wa minkum, taqabbal ya karim. Mohon maaf lahir dan batin. Terima kasih semuanya. Salam sehat untuk kita semuanya. Selamat mudik dan berkumpul dengan keluarga besar.
Amin.
Amin, amin.
Terima kasih Pak Sekum.
Ya, sama-sama. Terima kasih.
Baik rekan-rekan, silakan mengisi post-test yang sudah dibagikan di kolom chat. Kemudian dengan berakhirnya Zoom ini, maka berakhirlah seluruh acara. Sampai jumpa di CPD Asia selanjutnya. Indonesia itu mendapatkan jadwal pada bulan Juni. Jadi kita ketemu lagi mungkin bulan Juni. Sebelumnya bulan Mei, kami akan sampaikan jika ada CPD selanjutnya. Baik, demikian yang dapat kami sampaikan. Bu Irma, silakan dilanjutkan.
Ya, sudah berakhir semuanya. Selamat merayakan, selamat menyambut Hari Raya Idul Fitri juga sekali lagi untuk Bapak Ibu semuanya yang merayakannya. Mohon maaf lahir dan batin. Mohon maaf apabila ada hal-hal yang kurang berkenan dari acara sore hari ini. Ya.
Ada yang maafkan, Mbak Irma, makasih banyak.
Terima kasih.
Ya, izin live ya. Terima kasih.
Selamat sore.
Terima kasih Pak Sekum. Saya izin end meeting for all.
Ya, silakan Bli. Terima kasih.